Welcome all for this monthly academic feast, especially brought to you by IIP Raigarh. And this idea is conceptualized by IIP Raigarh to bring a unique monthly academic feast on second Tuesday of every month. And our dear President Dr. Wankhede sir is a driving force behind that. So today we have stalwarts like Dr. Mahesh Sambari sir and Dr. Shekhar Patil sir to give us guidance regarding very common cases and practical tips to manage them. I request Wankhede sir to give his opening remarks.
Thank you, Vikas. Dear respected seniors and all my dear friends, as per our plan, we have already planned our program, and according to our plan, we have kept this second Tuesday of every month for subspecialty chapters. And I'm very happy that we are beginning with our own Raigarh IIPS Dr. Mahesh Sambare and along with Dr. Patil sir. Actually, there are two lectures. One is about epilepsy, case-based epilepsy. That lecture is going to be delivered by Dr. Mahesh Sambare. Epilepsy, particularly, we often discuss about our epileptic cases, some neurology cases, related cases with Dr. Mahesh now and then. So he exactly knows what is to tell or what exactly we want. And another subject is febrile encephalopathy. This subject, these cases also we often, not often, but we may get sometimes in our OPD. Sometimes we have to treat these cases, and to get our knowledge updated, Dr. Patil sir is here to guide us. So both the topics are very interesting, and that will be definitely going to benefit and add our clinical sense indeed. So thank you. Over to Vikas. Thank you very much.
Thank you, Wankhede sir, for this nice opening remarks. I request our dynamic treasurer, Dr. Sagar Khedu, to give introduction of speakers.
Yeah, thank you, Vikas sir. We do get we do get an expert opinion always from a great person from our field. But imagine how grateful it will be if these persons are among us and they are just a phone call away from you. Well, today for our neuro bit of our Raigarh IP, we have two well-known pediatric neurologists who had achieved a great trademark in their field, but they are definitely very close to us, and they definitely are among us. We feel they are among us. And they are here to just discuss our very common problem, that is epilepsy, and their epilepsy in our routine day-to-day practice. Our first guest of honor, Dr. Shekhar Patil sir, who had done MD Pediatrics and DM Neurology. He had done also fellowship from in a pediatric neurology from London. He is practicing in Panvel and New Mumbai territory. He is prominently practicing in Apollo Hospital, Navi Mumbai. He is today with us to discuss febrile encephalopathy. On behalf of the Raigarh IP, I will just welcome Dr. Sir. Thank you, sir. And another sir, Dr. Mahesh Sambare sir. He had done a DNB pediatrics. He had done a fellowship in a pediatric neurology from Wadia Hospital. He is presently working in the Panvel territory. He is also working as a pediatric neurology in a Wadia. He is, and not to forget, he is one of the dedicated person to work as a pediatric neurology in periphery of Raigarh, which includes Mahad, Mangaon, Raigarh. Sir, hats off to you for giving us a great service in a periphery. Well, sir is here to discuss regarding the epilepsy approach and their management. On behalf of the Raigarh IP, I just welcome Sambare sir. Thank you. I think with this, I will just hand over mic to the Vikas sir to carry forward. Thank you, sir.
Thank you, Dr. Sagar. And I will also, if possible, you can introduce our moderator, Dr. Sachin Murade.
We can start because we can start. There is no need of
No, sir.
introduction.
Yeah, sir. Just in brief, Dr. Sachin, sir, I feel you are among us. I mean, whenever we have problem regarding a pediatric intensives, sir is there. I just give a call. Sir will be there for your help. I think, yeah, handovers with Dr. Vikas, sir.
I thank you, Dr. Sagar, for this kind introduction of our speakers and moderator. Now I request Dr. Sachin to moderate the session henceforward. Thank you. Forward to Dr. Sachin.
Thank you, Vikas. Now, without wasting much time, I would request Dr. Sambare sir to begin his talk about epilepsy case-based scenario. So over to Sambare sir.
Share screen, no?
Yeah.
One brief announcement before sir starts. If you want to ask some question, you can ask through chat box, or if not, at the end of session, you can ask the questions.
So at the end of both sessions, we will have questions for both the sessions. So please do send your questions in chat box.
Is screen visible? Hello, Sachin?
Yes.
Yes, sir.
It's
Yes.
visible. Yeah. It is visible.
It is visible, sir.
Okay, so let's start. So good evening all. Thanks IP Raigad, Wankade sir and his team for inviting me. Basically, it's my home ground and it's fun to play on home ground. Though we have most furious bowlers here in our team, but I'm used to face them. So let's start with the first case. This will be basically case-based scenarios which we all have faced in day-to-day OPDs. Let's start with the first one.
असं त्याला म्हणतात कर्नाटक स्टाईलची.
Hello. So
Yes, sir, go
let's
ahead.
start with the first case. It's 9-year-old girl, developmentally normal, non-consensuous marriage, no risk factors. Seizure onset at 8 years of age, nearly always in sleep, gets up with hemifacial twitching, gurgling sound, excess salivation, communicates partially with gestures, could not articulate, conscious but not that as normal. Always brief episodes, seizure frequency once in every 2 to 3 months. So this is a seizure which is somewhat localized to perioral areas with gurgling sound, salivation, always in sleep. MRI normal. EEG showing bilateral centrotemporal epileptiform activity. So this is the one of the commonest epilepsies or seizures what we see in day-to-day scenario. Diagnosis is very straightforward.
Right.
Diagnosis Beck's. Exactly. So these are the Rolandic seizures or Beck's, which occurs in sleep, which occur in normal school-going kids, which are brief, infrequent, and usually associated with deviation of face, twitching, gurgling, excess pools of saliva. So this is the commonest epilepsy, what's called as Beck's or Rolandic epilepsy. Being a focal seizure, drug of choice is carbamazepine. So this patient was started on carbamazepine, adjusted to 20 milligram per kg, was seizure free. Has again seizure after more than 3 to 4 months interval. So carbamazepine dose was stepped up. So after that, no complaints, but patient presented after 10 days. So till now it's fine. So it's like Rolandic epilepsy, focal seizures, started on carbamazepine, that's fine. But the presentation came with marked behavioral worsening, aggression, stubborn behavior, head banging, not listening to anyone. So this kid was somewhat totally different what I've seen maybe before. So what may be the possibility? This patient is with epilepsy on medication, so it may be associated with epilepsy itself, it may be associated with drug itself, or it may be associated with somewhat totally different from this scenario. As patient was on carbamazepine, the levels were sent that came to be normal. So what's next? So one single investigation that is performed was EEG, and EEG, that's also a sleep record. Why? Because this was what we got. There were runs of epileptiform discharges throughout the record, throughout the sleep record from start to end. And this is what is called as CSWS, or continuous spike and wave discharges in slow wave sleep. This is a form of epileptic encephalopathy. Sometimes, rarely we get with a normal or benign epilepsies, particularly with those on the Rolandic epilepsy on carbamazepine. So, though the epilepsy or the basic disease is a benign one, it may not take the regular course always. So, this was the EEG. So, carbamazepine was taken off, started on valproate and clobazam. Patient was seizure free. Later on, clobazam was taken off and was on continued with valproate. Behavior was back to normal. So, this is what is called as drug-induced CSWS or carbamazepine-induced CSWS. This is a continuous spike wave discharges in slow wave sleep. This is a form of epileptic encephalopathy where seizures are not that prominent. What we see is that behavioral worsening, which is a part of encephalopathy. So we have encephalopathy with underlying epileptiform activity on EEG. So it's an epileptic encephalopathy without prominent seizures. So though we have a benign disease, the course may not be benign always. So in this case, take home message is any patient with acute onset behavioral worsening EEG, particularly awake EEG and sleep EEG, awake to see for background activity and sleep to see for epileptic encephalopathy. Second, epileptic encephalopathy can present with occasional seizures or sometimes rarely without seizures also. So it may not have a daily seizure, multiple seizures. So when you are suspecting epileptic encephalopathy, always keep in mind that it may not be always with marked seizures. So this was the first case. Any questions or we will take last? Hello, Sachin.
Question we'll take at the end of the session, sir, because again, that will extend our discussion then.
Okay, fine. So let's move on to the another case. Informant uncle, 12-year boy, developmentally normal, studying in 7th standard. So daily multiple episodes of becoming blank, uncommunicable, unresponsive, lasting 5 to 10 seconds only, but never fall. And this used to happen 100 times a day. He received scolding multiple times from teachers, parents for not paying attention. And this was going on for 6 months. So diagnosis is?
Absence.
Absence, very straightforward diagnosis. So absences are something which occurs nearly always in seconds, and they always in hundreds. It will never happen that you will have one absence now and second after 15 days. So very common presentation and very, so episodes, as sir has said, it's absences. How to confirm in OPD? One simple procedure will confirm this in the OPD, and that is hyperventilation. So just ask patient to hyperventilate. Hyperventilation, how it is, it's usually by holding a piece of paper in front of your face and blow it. Blow repeatedly, continuously for 2 to 3 minutes. And nearly 90% of them, they will get absence. So practically diagnosis of absence is in the OPD and not following investigation. And they have classical EEG or they have signature EEG. If you see that EEG, there is no differential but absence. This is the classical absence EEG where you get 3 Hz generalized burst. 3 Hz means from between these two, these are two lines of 1 second. What you have is 1, 2, and 3. And these are generalized burst. So you have a generalized burst at 3 Hz that lasts for maybe 4 seconds to 10-20 seconds. Rest all of the EEG is practically normal, and this may occur with hyperventilation and many times without hyperventilation. And second thing, if you get a normal EEG even with hyperventilation, not on treatment, is less likely to be absence. So practically always you get abnormal EEG with absence. So drug of choice. So absences, as we said, these are multiple a day. Absence never happens once or twice in a week or 10 days. Practically always in developmentally normal kid can be provoked by hyperventilation in more than 90%. So if you have a negative HV properly performed, less likely to be absence. EEG we have discussed. Now we have a childhood absence which occurs in is different from the normal. Your age onset is below puberty. These are isolated absences. So no GTCs, no myoclonic seizure, no other type of seizures. They have carries a good prognosis, nearly 90% resolution, while juvenile absences, they occur in the adolescent age group. And most of them, they are associated with either GTCs, they are associated with jerks, myoclonic jerks, and these are part of idiopathic generalized epilepsy. So here complete resolution is very less. So less than 50%, they will have resolution, and most of them will have to continue seizures even in the adulthood. So drug of choice, drug of choice, what should be remembered that drug should not be used in absence. So if you are suspecting absence, never use this drug. So keep this first in mind before what drug should be used. So never use this drug. This is highlighting point. First, which drug to be used now? As we have seen in UG, read in PG, the drug of choice for absence is ethosuximide. Fortunately, it's available now in the last few years in India. This should be used in childhood absence epilepsy and not in juvenile absence epilepsy. The reason for this is what juvenile absence are associated, what we have seen are associated with GTCs. They are associated with myoclonic jerks. Ethosuximide is a drug that acts only for absences. That will not take care of other type of seizures. So if you are suspecting like juvenile absence, the other drugs like valproate, lamotrigine, levetiracetam should be drug of choice. In childhood absence, still valproate we use very common with quite a good response, or ethosuximide now available. It's only one brand available of Sun. So this is the absence epilepsy. Take home from here is something which looks very similar to absence and practically always referred as absence are dialeptic seizures or complex focal seizures. These are very similar. They have behavioral arrest, they have staring, they have minimal activity, loss of consciousness, but these are infrequent. Once in 10-15 days a month, they are prolonged. They last for minutes. Absences practically always are in seconds. And most of time they have automatisms and they are preceded by aura. So though they look very similar to absence, should be differentiated from absence. So when you suspect absence, always ask patient to hyperventilate in the OPD. So you will get diagnosis in OPD itself. And second, again, absences are hundreds a day, never, and they never fall. So these are simple, very common seizures and should not be missed. So let's move on to the another case. 11-year girl, developmentally normal, 4 episodes in last 2 years, all in school during prayer except one that was also in the mall while standing. Episodes were blackening in front of eyes, feeling weak, followed by loss of consciousness, becomes limp and fall. Never had major injury, gains conscious within 2 minutes. So diagnosis? Syncope. So very straightforward case. Diagnosis was syncope. Patient came with these reports. MRI done, that was normal. EEG done 1.5 years back, that was abnormal. And this was properly abnormal. I have seen the printout, that was properly bilateral centrotemporal epileptiform discharges. So genuine abnormal. So started on levetiracetam by pediatrician. So whether it justified to start with antiepileptic or still it's syncope?
Syncope. Still syncope.
Still syncope. Why?
History.
Exactly. So you have that. So we have that gem of clinician in us. So so though EEG is abnormal, anyway we are not convinced at all. The history is classical of syncope. You will never get this type of episodes in seizures. That aura or pre-syncopal aura, like blackening in front of his, feeling tiredness, tingling numbness. So this is classical pre-syncopal aura, becoming limb, fall, always in standing position. So very likely to be syncope. Then why EEG is abnormal then? But still it's not convincing. So what was done is what is called as head up tilt table test. And that was abnormal, which confirms to be a vasovagal syncope. So sometime it may be a confusing, but still, if you are very much sure about your diagnosis, stick to it and process accordingly. So vasovagal, we all know. Regarding what should not be missed is cardiovascular or the cardiac syncope, which carries very high mortality, sudden deaths. These are syncope which occurs at the peak of exercise. So those with marathon runners on gym, they die because of this. Their absence of premonitory or pre-syncopal aura, and they require detailed cardiac evaluation to rule out structural and functional cardiac defect. So from this take home is history and clinical diagnosis is always on the top of all the investigations. So this never should be missed. And EEG can be abnormal without epilepsy. Though this is not very common scenario, what we get abnormal EEG without epilepsy is very likely to be erroneous reporting. Or truly abnormal EEG with an epilepsy rarely have, and very likely to be Rolandic epilepsy, because it's only 1 or 2 of the 10 patients with abnormal EEG throws seizure. So rest all 8 or 9 will have an abnormal EEG without seizures, and this patient was one of that. So you may have an abnormal EEG, though rarely, without epilepsy. And EEG can be normal with epilepsy, that we all know, and we are very well know this fact. So let's move on to the next case. 16-year boy, single GTC lasting 10 minutes in the airport in the early morning, admitted in the hospital, MRI done, that was normal. So this is very common scenario what we see in pubertal age group. EEG, which was classical, burst of generalized polyspike wave discharges. So patient was started on valproate rightly. So diagnosis?
Within my class.
So it's idiopathic generalized epilepsy basically. So the epilepsy that's developing a normal kid with GTC without any other risk factor. And they have a classical EEG pattern where we have burst of polyspike wave discharges with absolutely normal background activity. And this is a book picture of idiopathic generalized epilepsy, what is either JME, JE, or GTCs. And many of them, they have positive photic response. This is the photic stimulation ongoing, and you have that ongoing burst over there. So this is ideal EEG of idiopathic generalized epilepsy. You have a normal kid, you have a normal MRI, with most of time you have an abnormal EEG. Many times you have normal EEG also, and that occurs in nearly half of them. So, idiopathic generalized epilepsy is basically epilepsy what we see in adolescent age group with GTCs. So, when any patient present with single GTC, rest all normal, always ask for this one, myoclonic jerks. So, majority of them, they will have a morning jerking. So, they may have maybe a cup of tea falling from the hand or while combing. So they are brief jerk which always they are likely to be missed. So any patient presents with GTC always ask whether he gets more myoclonic jerks, particularly in the morning time. And unless you ask, they are not going to tell you. Also, they are prone for abscences. So idiopathic generalized epilepsy may have these three components. In this case, what we have is GTC. They may have myoclonic jerks and absence also, or they have myoclonic jerks with occasional GTC or no GTC. If this is there, it's GME. If this is there, absences are there. What we seen before, that absence. So without GTCs, in that case, at this age group, it's juvenile absence. Or maybe a GTC on awakening, where they have isolated GTCs, otherwise know this thing, but they have a characteristic EEG. So basically, idiopathic generalized epilepsy is a pubertal onset epilepsies which have either of these components or all of these components. So how to go ahead with this? Now, the drug of choice is decided by the comorbidities present at this time. Because most of the pubertal, they are overweight. Most of them, they have migraine or they have behavioral issues. If the patient is overweight, the drugs that causes weight gain should be avoided, like valproate. Rather, the drugs which causes weight loss should be added in that case, which may be helpful in this, like topiramate or zonisamide. Migraine, so the drug which acts both for IgE and for migraine, like divalproex, can be used here. Depression, anxiety, so there are certain drugs which precipitates depression, which causes suicidal tendency, and the commonest and most commonly used drug is levetiracetam. So when you have behavioral issues, always avoid using levetiracetam. It's practically contraindicated. What should be used is like lamotrigine, which have that stabilizing effect, or divalproex, which has that stabilizing effect. Also in females, the drug valproate should be avoided because that will cause weight gain, hair loss. So all these side effects which are common in females, therefore valproate can be used but not the first drug of choice. Lamotrigine can be used safely, levetiracetam can be used safely, but many times we see a breakthrough seizures with this. So in that case, we can use just a minimal dose of valproate as an add-on to this, and that will take care of the relapses. Now, in case of male, valproate can be used. If has relapse, lamotrigine can be used, levetiracetam can be used, or any of these drugs like topiramate, clonazepam, clobazam, phenobarbital can be used. Phenobarbital particularly if affordability is an issue. Even phenytoin can be used here, though we never use in the pediatric age group. Maybe adolescent or in adult can be used. But the drug should not be used is again carbamazepine. Carbamazepine precipitates IgE, so should be avoided. So any pubertal patient presenting with unprovoked GTC always ask for myoclonic jerks, always ask for absence seizures. Choose AD depending upon comorbidities. Very important at this age, and very important that majority of them, more than 50%, they will require antiepileptic even in adulthood or even lifelong. This should be very well counseled to the patient. So these cases we have seen in those kids which are normal. Now let's move on to those kids which are abnormal or which are delayed. So for delayed common scenarios, again, we have considered till now all the common scenarios the same way we'll consider in those with delayed kids. 8 months, full term normal delivery, NICU stay on day 3 for lethargy and seizures. Day 3 seizures very likely to be hypoglycemic seizures unless otherwise proved. So we have developmental delay, microcephaly with poor fixing, so some visual impairment. As most of those with hypoglycemic, they have cortical visual impairment. So fixing tracing, if we have a microcephalic kid with NICU stay with poor fixing, very likely to be neonatal hypoglycemic brain injury. Developed sudden jerky movements of trunk extremities in cluster after getting up from sleep. This is classical infantile spasms. The age, common age 5 to 6 months by 1 year. This is the common age to present with. And along with this, there is irritability. Usually these spasms occur after getting up from sleep. They usually occurs in clusters and they are followed by either lethargy or very commonly irritability. There is progressive loss of smiling, cooing, and EEG showed hypsarrhythmia. And this is the classical hypsarrhythmia. For this diagnosis, symptomatic waste. This was the MRI. What you see here, this is T2 axial images where you see a prominent scarring over the occipital region symmetrically. Bilateral occipital lobes are practically fired, and this is classically you get with neonatal hypoglycemic brain injury only. If you have this, it's less likely to be a prominent HIE, it's very likely to be a prominent hypoglycemic injury. And as we have here histories on day 3 admission, we have classical clinical presentation, we have classical MRI, and this is the EEG what we see. We have hypsarrhythmic pattern, which is chaotic pattern, high amplitude with burst separations, electrodecremental response. So this is a classical modified hypsarrhythmia pattern. So patient was started on ACTH, which was given for 1.5 to 2 months, gradually tapering, after which the spasms settled completely. We can also use vigabatrin, which was that time not available. Now it's quite freely available in the sachet form. The dose of vigabatrin is 50 to 150 milligram per kg. And nowadays it's both ACTH and vigabatrin should be combined to have a heavy hit at the initial phase. Because being a form of epileptic encephalopathy, if EEG doesn't improve, there is chance of permanently cognitive retardation in these kids. The other drugs can be used are topiramate, valproate, zonisamide, nitrazepam. The drug should not be used again is phenobarbital, carbamazepine, oxcarbazepine. So for each and every scenario, you have some drugs should not be used. I think from today's talk that should be kept in mind, like what should be used, we all know. What should not be used, we should know, and that's very important because that worsens seizure. So these drugs can be used. After this was the EEG which practically became normal after that, which rarely we see with. So the patient stopped coming, doesn't turn back for years maybe, lost follow-up, and visited maybe 7 to 8 years later. And now, in between, he used to get minor head drop, but no one bothered of that because there was no prominent proper seizures. So this was going on, but presented now. It's why? Because the episodes were increased. So brief episodes of becoming blank, unresponsive. These looks like very likely like absences. These are called as atypical absence because these are infrequent, these are prolonged, and there is not complete loss of, there is maybe a partial loss of consciousness. So atypical absences you get in delayed kids, while classical or typical absences you get in normal kids. Along with that, head drops were there, complex focal seizure were there, but the reason why patient came now is daily fall on face multiple times causing injury to the head, face, nose. And these are tonic falls, tonic log-like fall. So the patient falls like a log and he could not protect himself also. And this is what happens. This is the classical EEG, what is called as slow spike wave discharge. The similar EEG we have seen with absences, but that time it was 3 hertz. Here it was 1.5 hertz. So this is called a slow spike wave burst, which is classical or which is diagnostic of what is called as Lenox Gestalt syndrome. And what we have seen now, these are the common hits. This is not a single injury. It hits, it heals, it again hits on same area, it heals, it hits. So this is multiple times a day. Multiple times a day, it's very difficult to control or even protect. Many of them, they have head injury, they have bleeds, even intracranial bleeds. If you can see here, these are the head that's banged n number of times. We have this another also. So when we see about syndrome, Lenox Gestalt syndrome, we feel like this is something once in a while we will see in our life. These are the syndromes which see day-to-day OPD. At least once in a week, 10 days, these are patients coming throughout. And these are all those patients who develop HIE, who develop neonatal hypoglycemia. So these over a period, they evolve in LGS. So initially they have West syndrome, later they have a LGS. And this is quite common. This is one of the kid. This is the second kid. Same. You have n number of banging, heals, again same injury at same place, heals, injury again at same place. This is another one. Same. Another similar injury. Hits, heals, hits again, heals. So this is so common. Next one. If you can see here, hits n number of times, it's healed, again hits on same time. So LGS, they are characterized with this tonic fall. And this is again same one. If you can see here, these are swollen eyebrows. These are not swollen, these are bleeds underlying. You have injury on the face. So it hits on the face like a log. So we have seen so many patients. These are just few patients I clicked. There are n number of patients. They are coming to me and they are all referred by you. So LGS is something which I've seen by each and every one and should be kept in mind that these are the refractory forms of epileptic encephalopathies. So we have West syndrome initially, later on they evolve into LGS, and these are epileptic encephalopathies. Drugs which are effective here are valproate, clobazam, and high dose of lamotrigine valproate, clobazam. So this is the classical combination we use. Still topiramate, levetiracetam, all those, they act as a supportive one, but valproate, clobazam, lamotrigine, this combination acts to some extent for LGS. Many of them, they require initial pulse with methylpred and oral prednisolone, like what we do with West syndrome. But if it's uncontrollable, then it's surgical option where they do corpus callosotomy. This is something which will not take care of seizures, but they take care of tonic falls. And what they are more bothered, what is more bothersome for them is tonic falls. So if it is really refractory, unresponsive, they can go ahead with this one. Again, the drug should not be used in all these encephalopathies are carbamazepine, oxcarbazepine, and phenobarbital. So take home message is be vigilant for infantile spasms because they doesn't look like proper seizures and they are always missed. They are very likely to be missed by parents and even by the clinician if they don't, we don't ask positively for that. So if you have a history of NICU stay, if you are seeing a microcephalic kid, if you have a history of neonatal hypoglycemia, always ask positively for dazaktaka, husaktaka, झोपेतनं उठल्यानंतर. So ask for infantile spasms and treat infantile spasms aggressively because they will lead to permanent cognitive delay if we don't treat them in time. Thank you.
Thank you, sir, for your case-based scenario of epilepsy. including pharmacotherapy in each of the various types of benign as well as progressive epilepsy. Vikas, should we take questions now, or should we wait? Should we complete the presentation of Patil sir, and then we should take question and answer for both the sessions?
It depends upon how many questions are there. If there are too many questions,
there are 4-5 questions in chat box.
we can finish them.
5-6 questions are there.
I think we will take last only because that will go on. The question answer session will go on.
Actually,
so that will.
Yeah.
So once we finish the talk, we can have a dedicated session for question answer only. So that may continue for whatever time required. We can.
Okay.
Yes, sir. So we will move on with Patil sir's presentation then. I would like to request Patil sir to start with his presentation of acute febrile encephalopathy. Over to you, sir, Patil sir.
Can Mahesh stop sharing?
Yeah. Sorry. Zala?
झालं. Okay, so can you see my screen?
Yes. Yeah, it's visible.
Yes, sir.
Yes, sir, it's visible.
Good. Thanks for the IIP Riga team to give me the invitation, and especially Mahesh to actually just pitch in. He always is a colleague where we normally share the dash together. So I thank the team, and we'll move on with the session. So the topic was acute febrile encephalopathy, and what we are going to do is probably look at the definition. We look at the clinical cues, look at investigations, and then talk a bit about management, and we'll run through a few scenarios when we actually are going through the investigations part. Now, the most important thing is that you actually look at acute encephalitis syndrome, acute febrile encephalopathy, most of it as like viral encephalitis. You look at it as a package because the package will be the same. So it will be when you actually open the wrapping, what you see inside will be the clinical cues, which will be from the general examination, something from the history, something from the imaging, and then you would probably reach to the final diagnosis. But otherwise, if you look at someone who's coming to the hospital first time, it will be always the same scenario: fever, seizures, altered sensorium. Everything presents in the same fashion. You should slowly unravel the whole story. So when we talk about acute febrile encephalopathy, what we're actually meaning is the story is very short, history of less than 7 days, maybe a few hours in certain settings. Absolutely, as the term goes, febrile, which means that I have to have fever of more than 38 degrees Fahrenheit. And what we actually talk about is encephalopathy, where we are actually describing diffuse dysfunction of the brain functions. So it means that you are in altered sensorium. You may not have focal neurological deficits. Seizures may or may not be there, but it's just altered sensorium primarily with or without deficits and seizures. So this scenario put together would be an acute febrile encephalopathy. Multiple causes, but the commonest one that will come to the clinical setting would be a infective cause for the febrile encephalopathy. Now, we always talk about encephalopathy, encephalitis. Now, encephalitis is something slightly more than encephalopathy. So it's like they will always have encephalopathy, but in addition, there will be evidence of direct inflammation, and you will have direct invasion of the cortex. You will have CSF abnormality, imaging abnormality, with or without an EEG abnormality. So all in all put together, you have this picture of encephalitis, and the original definition of encephalopathy, the part and a few features of that will be again matching with this encephalitis. So now when we are actually looking at this differentials now, so when we talk about differentials, the first thing we are always looking at the infectious causes vis-a-vis the non-infectious causes. So when we look at non-infectious causes, one entity which now really stands out is fires or NORS. Now, not just because it is common, it's highly common, but the important factor here is that it's very difficult to control these seizures. They end up with refractory or super refractory status, and that requires really difficult ICU time and multiple medications at the same time. When we look at the other group, that will be para-infectious or post-infectious demyelinating disease. So we're looking at ADEM or ANAC as a clinical condition, but it starts off with a mild viral coryzal illness and ends up with a demyelinating disease, primarily due to the host immune response. And then something new which we really need to consider for all these encephalopathy scenarios, where the presentation could be of a febrile illness in nearly 50% of the cases. Otherwise, autoimmune encephalitis will have seizures, behavioral issues, and regression of skills. But 50% will have seizures. So that's the reason you have to consider in a differential for an acute febrile encephalopathy with seizures. The commonest pediatric autoimmune encephalitis would be an NMDA receptor mediated encephalitis. The other ones are not very common in pediatric population. So always keep your eyes and ears open to listen to these things or observe these things and reach a diagnosis. Then we have the actual others. So rheumatological causes, systemic causes, toxins, traumatic. So you can have accidents, you can have road traffic accidents, you can actually have a non-accidental injury, which can have febrile illness and encephalopathy. So the imaging would be important. Space occupying lesions. So sometimes you just have fever as a part of a central fever, and then you have these space occupying lesions. Look at, they are space occupying. So that is where we're really looking at the infectious, non-infectious causes. Rheumatological causes are not that common, but yes, you should be aware of these things. Now let's look at each one in detail. So we'll look at infectious causes. We actually segregate them into viral, bacterial, or parasitic. So when you're looking at viral, the ones that we really are looking for are flavivirus related or arbovirus related. So we're looking at JAB, dengue, West Nile, which is now still common, influenza, enterovirus, HSV1 and HSV2, zoster encephalitis, EBV, HIV. So these are the common scenarios that we see, but yes, overwhelming would still be the JAP in depending on which endemic area we are practicing. Bacterial, primarily for the pyogenic meningitis, strep pneumonia still common. Tubercular meningitis mixed can be seen when you actually have the infiltrate or the primary sinus continue being broken and then spread into the subdural space. Salmonella, leptospira, again history would be for a GI problem or someone playing in sort of dirty water and that sort of scenario. Gram-negative sepsis, not very common in pediatric population, but in a setting. So let's say someone has a renal issue and he probably has recurrent UTIs. The gram-negative sepsis can again manifest as acute febrile encephalopathy. So you may have scenarios specifically to a particular individual. Rickettsial illness, so looking for eschar, tick bites, so that is very important. And you have cranial nerve paralysis, then you think of rickettsial illnesses along with febrile encephalopathy. Parasitic, malaria, toxoplasmosis, so again specific setting for toxoplasmosis, immune suppressed states. Malarial illness again in overlapping with your endemic states for JAB and dengue. So when we look at again the same differentials, fires or NORS, the difficult scenario. When we look at para-infectious demyelinating, we're talking about ADEM or acute necrotizing encephalopathy, NMDAR, Casper-2, which was the subtype of voltage-gated potassium channel antibodies. Rheumatological causes, so SLE, if you have a story of SLE, mixed connective tissue disorder, and now in the current setting, what we are seeing, COVID-like illnesses, we're talking about macrophage activation or multi-system inflammatory disease. So that's the MISC variety that we are seeing. So this presentation will again be an acute febrile encephalopathy, but your lab parameters will probably give you the diagnosis for a proposed rheumatological clue. Systemic, so we're looking at Shigella, typhoid, gram-negative sepsis, malaria, organ failure. So you can actually think about someone who has liver failure or renal failure can present with systemic causes for the acute febrile encephalopathy. Drugs, toxins, we're looking at vaccine-induced, again, the same demyelinating illnesses, anticholinergics. So we have so many kids who we are on aspirin, but that's a specific group again. But trihexyphenidyl would be an important cause here. Poisonings can present with encephalopathy and associated fever sometimes. Traumatic, yes, road traffic accidents, non-accidental injuries. Space-occupying lesions would be tuberculomas, any malignancies, metastasis, the whole picture. And last, metabolic causes. So we do not actually entertain metabolic causes when we're talking about acute febrile encephalopathy, but they may be part and parcel of the entire picture, not necessarily the entire cause, but an associated cause. But what we need to remember is inborn errors of metabolism can present during that acute illness with decompensation. So a differential for inborn error of metabolism should be considered whenever you see a first acute febrile encephalopathy. Low sugars, high sugars, DKA-like situation to be thought about. Aspirin use in under 12 is not very common, so Ray's syndrome scenario would not be seen. Electrolyte dysfunction, yes, when you're seeing a diarrheal illness, but then again, you will actually have the diarrheal illness and the encephalopathy. Electrolyte dysfunction may just be a part of that whole picture. Now, when we're looking at this, so we now have etiology, so that we're at presence of rash,
Shekhar, you are not audible.
Background noise. Can you hear me now?
Yeah.
Yeah.
Yes, sir.
Yeah. So then you have the maculopapular rash, the eschar, purpura symptoms, which can actually point towards specific etiologies. We have the respiratory symptoms, so upper respiratory tract illnesses. So again, you post-respiratory flu-like viruses, which can be the etiology. GI symptoms, enteroviruses, again typhoid. Travel endemic diseases. So if you are aware of certain scenario, certain conditions or diseases which are endemic to areas, and if you have traveled to those areas, then that may actually give you a clue. History of infectious disease in contacts. You primarily suspect tuberculosis contacts or some other infectious disease in close contacts, then the same scenario can be, etiology would be in the current scenario. Myalgias, arthralgias, chikungunyas, and dengue possibly. Look for administered drugs, which can be the overdose, or look for recreational drugs. Someone who would be the right setting, right age, like teenager with some delinquency and that sort of setting, you would think of recreational drugs. Always remember our endemic monsoon illnesses. The season arrives and then you would have a flurry of those cases. And animal or animal bite primarily for rabies, and mosquito bites, again the same setting for the monsoon-like illnesses. Now, this is the epidemiology of the viral illnesses. So if you look at West Nile, so the West Nile as a part of in the Indian map, and JE. So these are the commonest ones that we are actually looking at. The tick-borne encephalitis, which is the Western and the Far East, not really seen. Looping viruses is in the Western European countries, and St. Louis encephalitis primarily in the North America. But we're looking at West Nile and moving continents, going towards the center and South America as well as GE now migrating there. So yes, movement of these viruses is primarily linked to the travel and in the world we are living in. Murray Valley encephalitis not seen really. It's primarily in the ocean countries, which means that Australia and New Zealand, but not really in Asia and Southeast Asia. When we look at the incidence of meningitis, now when we look at the incidence, probably like you look at this red one, which is seen here on the map in Africa, which is the highest incidence of meningitis, primarily looking at 200 to around 220 cases. We're talking about South Sudan. So that is the one. And then probably in the orange one, so here you have Ethiopia, then Niger, Chad. So these are the countries in Africa which probably have a slightly higher incidence of meningitis. India per se is placed between 60 to 100 incidence of meningitis cases per 100,000 population. So we are also high up. There was a study which was done, this was done in 2013 in a single tertiary center, 86 patients, looking at the cause of the febrile illness and looking at the etiology of the organisms. Small number for tuberculosis, but yes, looking primarily at the bacterial causes and meningitic presentation included neonatal cases. So around about 20 neonatal cases out of 83 patients. So maybe some of the organisms are slightly different because you have varied population, but we would all be seeing varied population. So you need to be aware of these spectrum. Strep pneumoniae, E. coli, Staph aureus still the number one, maybe in a hospital setting. Rare scenarios would be Citrobacter, Acidobacter in our. So again, just the prevalence of GE infection, look at the number of states which are highlighted in gray, and we are in an for the viral illnesses, if you look at Central Asia, Southeast Asia, we have chikungunya, dengue virus, EB71, JE, Nipah virus now, rabies virus, and then the rickettsial species, and one angiostrongylis. So this
Shekhar, network issues.
Sir, you're not audible, sir. Hello.
काय झालं रे विकास?
There is some network issue with Patil's connection. So, Vikas to call
Sir, join sir.
yeah, so we just switched off to a different network. So just yeah. Okay. So we're looking at neurological examination, and we're talking about general physical examination, primarily looking at the hemodynamics, check for icterus, rash, organomegaly to give you clues. Of course, assessment would include the presence of meningeal signs, GCS, look for signs of raised ICT. If everyone can do a fundus examination, would be always welcome. So you can look for papilledema ourselves, and then look for evolving movement disorders like dystonia and curiform movements. Now, when we actually look at Japanese B encephalitis, the evolution of these movement disorders will probably give you a clue that we are looking at this group of disorders because they're very, very common. So a predilection for the brainstem structures and predilection for the basal ganglia structures. Paraparesis, if you're looking at demyelinating diseases where you have the myelopathy also setting in along with the encephalopathy, then you can actually see, check for paraparesis. Now, in general examination, what we actually are looking for is, this is the zoster rash. This is an S-char. If looking at this screen here on the left, on the right of your screen, the hand which is showing, this is the actual typical rash of dengue with these paired islands which are seen. And then the fundus photograph, which shows a very bad papilledema along with the hemorrhages that are there. Now, ideally, what investigations we would be doing? So you should have your simple test where you have the complete blood count, blood sugar, renal, liver function test, blood smear for parasites, always check for dengue, blood culture, electrolytes. So your routine tests. And within that, you are supplementing the specific test, which would point towards an etiology. So this is what we're talking about, neuroimaging. And we're talking about CT scan, MRI brain plus contrast, spectroscopy in a very relevant setting, that too only on depending on what we find on your routine brain scan. And then EEG. EEG is important to ensure that you're not missing out on non-convulsive status as a possible etiology for your encephalopathy. And then we look at the CSF study, always ask for routine AFB, gene expert cultures. And in this day and age, you definitely can send for viral panels by PCR techniques. And there are certain labs we actually offer acute encephalitis syndrome panels, which you will send a CSF and a blood sample, and then you will have bacterial, parasitic, and other organisms as also in addition to the viral etiology. So all in, but yes, a costly affair. So what if someone can afford it, definitely something to look forward to. And then the other test, not to always forget IEM as a presentation, because triggering illness may have this encephalopathy related to IEM. So not to miss out on them at all. In terms of general treatment, so we're looking at ventilation, oxygen, IV access, food boluses, identification and treatment of the raised intracranial pressures. Always look for seizures and watch for evolving movement disorders. So that is what we're really looking at. Specific treatment, not much really to offer, but when we look at a specific setting of sort of pyogenic meningitis, rickettsial illnesses, you would think of doxycycline, azithromycin. You would for pyogenic meningitis, a combination of ceftriaxone and vancomycin. Looking at gram-negative sepsis, meropenem may be an appropriate choice. When you're talking about tuberculosis, yes, anti-tuberculous therapy, be it first line or second line, anti-malarials in an appropriate setting, antiviral. So we actually have only acyclovir, which is specific for the herpes group. The other viruses really, I mean, yes, H1N1, you do have oseltamivir, and you can use foscarnet and jancyclovir for CMV, HHV6, but far short. So the actual treatment that we really have is acyclovir. Use of steroids in specific settings, edemas, tuberculomas, probably in para-infectious demyelinations, and never to forget anti-seizure medication, which may be required for the setting. Now, as I said, the package will always be an acute encephalopathy. So I'm going to start with a single scenario, just a case to how a typical child may present to you. But then I'm going to discuss features that will actually segregate them. So to looking at a 3-year-old boy with a short coryzal illness presented with seizures, altered sensorium, normal general examination, sense the general physical examination, and there's never a significant past history. Now look at different scenarios, what the MRI may actually give you as an etiology. So when you look at this image, so you look at the yellow arrow and the red arrow, we are looking at areas of the brain which are affected. Hello? Yeah.
Yes, with some disturbance. Sorry.
So then we hyperintense signals in the medial temporal lobes, which are seen in the right-sided scans, and then you have the cortical involvement, which is seen on the two scans shown separately. And what we are seeing here is the insular cortex. The red arrow points toward the cingulate gyrus. And given this imaging features, we actually make a diagnosis of HSV encephalitis on imaging. Of course, we may pick up the HSV virus. So that we will discuss about the treatment, 14 days, 21 days, when to call relapse, recurrent, and also to be aware of evolution into NMDAR receptor encephalitis following an HSV encephalitis, because it opens up the antigens within the temporal lobe that can be then stimulate an immune response and an antibody response. So you can actually move from one condition to the other. So that is something which has been increasingly being observed. Now, this is a very typical non-specific setting for an MR imaging. You're just having cortical in hyperintensities. Of course, these are not infarcts because they're not in a typical vascular territory. So you would say that, yes, this is only cortical swelling. And then the group of viruses that you can see are, yes, the JAB-B and other things would be there, provided you have the predilection. Dengue may be there. But what would really come up here is enterovirus, EV71. Then we will have HHV6. So the rarer ones may be just for the cortical. But if I have the JAB-B may have the cortical one as well, but they can have their predictions for the thalamus and the brainstem. So this is what we would see for a viral encephalitis of some other type. And then you can actually have just this picture also. So all pictures are for viral encephalitis, but the separation. So the first one was very specific. The second, yes, you can actually look at certain viruses which will give this imaging and certain viruses which will never give this imaging. So that is how we differ. And this is another general picture that we see of. But mind you that some of these images actually look like swollen basal ganglia, and the radiologist may report it as Leigh disease, probably putting you through a mitochondrial condition. But remember that even viral encephalitis can have just the basal ganglia involvement, including the caudate and the putamen. So what we are looking here are swollen basal ganglia, including the caudate nucleus, blue arrow, putamen, the red arrow. And then you have the cortex, which is also swollen up here. So these features may help you to move away from mitochondrial disease. So if the cortical swelling is not there, it still could be a viral encephalitis. Now, this is the picture we see with para-infectious conditions. So we have hyperintense signal in the thalamus, we have hyperintense signal in the subcortical white matter, we have hyperintense signal in the basal ganglia, we have some cortical swelling which is seen in the subsequent scans. And then we have these widely spread out white matter conditions. So you can have thalamic involvement, subcortical white matter, cortical injuries, and periventricular white matter, and put together. So the symptom complex will be then ADEM. So acute. So this is acquired demyelinating encephalomyelitis, a close differential for AES, what's the acute encephalitis syndrome. Now, this is a scenario which is very difficult because this can be seen with influenza, dengue, and other viruses also. Flu viruses very commonly trigger this. So what you actually see are like bleeds within the thalami and swollen thalami. So this is the first A image is showing actually thalamic hyperintensity on a T1, which is again bleed, which is image, which is again bleed. So these features then put you towards something which is acute necrotizing encephalopathy of childhood, generally a very grave outcome. But if you have a child who is under 4, very difficult, above 4, the scenario may be slightly easier to manage. So age in this particular setting, I don't know why, but at this, there is this age gradient wherein some would do better if they are older and the younger ones don't do very well. Now, this may be the other setting. If I actually look at a slightly prolonged history of 2 weeks of fever and some sort of headache and altered sensorium and a seizure, and then I have a CT scan which is showing a dilated third ventricle, which is the red arrow, a dilated lateral ventricle, temporal horn, and a fourth ventricle, and a contrast scan showing some enhancing exudates around in the basal area. So this is hydrocephalus and basal exudates in tuberculous meningitis. So that is what we are looking at. Now, this is something which is very, so if I say this is a encephalitis due to some, so if I were to say this is hydrophobia, then what would be the differential? If anyone can actually pick up.
Rabies.
Yes, so the rabies here primarily because of this right side image where the arrow is pointing, actually showing a pontine step. So this is known as the step in pons, and this is actually rabies encephalitis. So that is how the imaging is. So sometimes this is what we look for and go reverse and make a diagnosis on imaging. Shouldn't be actually this way, but then there are scenarios where the imaging actually gives you a clue. Okay, so what is the role of EEG when we actually look at settings like this? So we are looking for slowing, which will actually just not be of any help, just suggest diffuse encephalopathy. Now, within this diffuse encephalopathy, if I have delta rhythms and I have this specific pattern known as delta brushes, so which is like sharp contoured waves on a delta, which is an extremely slow wave, then I would actually look at as an NMDA receptor mediated disease. If I have periodic lateralizing epileptiform discharges, yes, herpes would be the commonest one, but it can be seen in any asymmetric cortical injury because of any viral encephalitis. But what I'm actually interested is making sure that I'm not missing out on a non-convulsive status or very frequent seizures, and also the triphasic waves, which will point towards the metabolic encephalopathy. Now, this is what we're really looking at the EEG. So the first EEG showing actually just the delta rhythms or the very extremely. So if you actually have some contours on this, that will be the delta brushes. When you're looking at this right on the top, you're actually seeing that the first four and the second four, which is actually the right and the left, together are firing and showing continuous discharges, whereas in the second one, you're actually seeing on the left side. So you're actually having some migratory pattern within this picture. So probably in this setting would be, if it's just a status, then you would say that fires may be the presenting features. If you have imaging features for suggest any particular condition, maybe that is. So in this setting, it was actually the viral encephalitis, and this is the actual EEG of the patient who probably you may have heard about, who was at Apollo with the Boca virus. And this is again a same EEG for that patient who actually had this right-sided continuous activity going on. So difficult epilepsy, that is what we're looking at here. So when we're talking about febrile encephalopathy, what we essentially need to look for, segregate the infective vis-a-vis the non-infective causes, the neuroimaging plus the advanced techniques, primarily the PCR-based analysis for CSF would give you the clue. Etiology may dictate definitive therapy, because if you're isolating a particular virus or let's say rickettsial infection, then you may actually choose a particular modality of therapy. NMDA receptor has a completely different outcome, completely different medication route, no antibiotics, nothing, but just the immune-mediated therapy. And be aware of this entity, which we call as fires, NORS, autoimmune encephalitis. Meaning fires and NORS herald a bad outcome, but autoimmune encephalitis can have rewarding outcomes. So, thank you.
Thank you, Shekhar sir, for decoding such a extensive topic in terms of clinical history and investigation as well as neuroimaging. Thank you, sir.
Sachin.
Yes, Vikas.
Before going to question and answer, just I want to announce small announcement that I'm really happy to see this is one of the most well-attended CMEs. As from IPREG, we are very happy for that. And we are announcing this next month subspecialty CME of pediatric derma, which will happen around the second Tuesday of next month, and it will be more focused on management of acne in children, and also morning and evening skin routine care in adolescents. So we are going to have a very good faculty for that. So please join in next month again. Sachin, you can move ahead.
Thank you, Vikas. Now we will take question and answer. So first we will go to chat box. Dr. Chandorkar sir has asked about the question is for Sambare sir. Why MRI is not done in a first case? And his next question is juvenile epilepsy, the ones which are having a poor prognosis, can they have a good seizure-free period?
Which case?
In the first case, MRI was not done.
MRI was normal. I think I mentioned.
Normal. Yeah. And
MRI was
in juvenile epilepsy, the one which is having a poor prognosis, can they have a good seizure-free period?
See, regarding juvenile epilepsies, no, if you are considering about the idiopathic generalized epilepsies, juvenile epilepsies, about IGs, they have uniformly good prognosis regarding control. So they are well controlled. Even with a minimal dose of valproate, they are seizure free. Even for an adult, 200 milligram of valproate acts well, but they require that dose. Once you take off that, they relapse. So regarding control, it's well, they are easily controllable. But regarding off drug, it's very less likely that they will be off drugs. That more than half of them, they will require drugs for years, maybe lifelong.
Why EEG is abnormal in cases of syncope?
It's unrelated with syncope. Rather than many of the EEGs, they are abnormal in normal patients, in normal population. I will say that way. This pattern, no, see the typical classical pattern what they have. They have a Rolandic pattern. Rolandic pattern, these are types of like abnormalities where the proper clinical seizures are seen on only 1 or 2 of the 10 abnormal EEGs. So when you have diagnosed one Beck's patient, within that family, there will be 7 to 8 persons who will have an abnormal EEG, but they will not have seizure. So these are rather a general population which have an abnormal EEG. So in that case, but this pattern will be specific, like Rolandic epilepsy, like benign occipital spikes, focal sharps. So the classical pattern, like generalized burst, what you see with idiopathic general, it's less likely to be. So though we label as normal or abnormal, the type of abnormality and significance of that matters a lot.
Okay, sir. Okay, thank you. Now, sir, what is the mechanism of hyperventilation which precipitates absence?
See, hyperventilation is basically you lower down the carbon dioxide. In hyperventilation, so that's like respiratory alkalosis, which increase neuronal excitability, and that causes absence. So this is like you provoke absence. You induce you induce respiratory alkalosis, and that's the cause for absence.
So what is the possibility of absence just progressing to idiopathic epilepsy? Like what we have seen in the last case, that idiopathic epilepsy, you have asked the questions like whether this patient is having jerks or no.
So all this, no, it's absolutely dependent on at what age that absence is started. So if it is started by 4 or 5 years, what we see with classical absence, there's less likely that they will have a jerk. They will less likely they will have GTCs. If it is starting by 11-12 years, it's very likely that it's a form of juvenile absence. Childhood absence usually doesn't occur after 10 years. So it's that age, it's before puberty. It's only that peripubertal, no? So something like maybe from 9 years to 10-12 years. This is a borderline age where you can have either juvenile absence also, you can have either childhood absence also. EEGs, they have certain minimal differences in that, but most of them they are very similar. So see for the evolution. If they throw GTC, if the patient comes by 10-11 years, think that he may have a GTC. So treat accordingly. Okay. So rather than putting them on ethosuximide, it's better to put them on valproate. Valproate or some other drug which will take care of other epilepsies also.
Sir, Dr. Parvez wants to ask, how do we decide to stop anticonvulsants? That is a case-to-case basis.
It's absolutely individual. It's absolutely individual depending upon the type of epilepsy what you have, underlying cause, age of the patient. So all this matters a lot. So if the patient has no risk factor, in that case, maybe 2 to 3 years seizure-free with a normal EEG, that's fine. Many times, like these benign epilepsies, they have persistent abnormal EEG for years in adolescent also, but they may not throw seizures. So it's not mandatory like you need a normal EEG, but if you have an abnormal EEG with benign patterns, like Rolandic epilepsy, like benign occipital epilepsies, they may have persistent abnormal EEGs, but the patient may be seizure free. So if there is 2-3 years seizure free, you can take off and see for relapse. If relapses, restart. Otherwise, it's well and good.
Actually, sir, now looking at the pharmacotherapy of seizure disorder, nowadays levetiracetam is being extensively used. So I would like to ask both of you, so what is your opinion about this medicine? Should we use it as a first drug of first choice in each and every case of seizure till we get a neurologist opinion, or we get the diagnosis of type of epilepsy?
See, levetiracetam, it's something like a blanket coverage. It acts for practically all and type of seizures. It's safe drug, so no issue in using that. The only problem with levetiracetam, when you use as a first drug, it is not that efficacious. What's about Shekhar?
The only purpose we are choosing levetiracetam is primarily the ease of use. It is available.
Yeah.
You can actually give loading or injectable form when you first come into the setting of a ICU stay or a hospital stay. The other thing is about no drug interaction. You're not worried about the interaction about these medicines with the other medicines that you are actually planning to use. So in that sense, probably a safe drug because of less interaction. But in terms of the efficacy, it still doesn't match probably the earlier medication. So
Exactly.
probably yes, you can stick to use of levetiracetam, even though the original license was only for focal epilepsy. It has never been actually, when it licensed, it was licensed for the focal epilepsy.
And second, all those patients which are having some behavioral issues, depression, suicidal, rather what we see is ADHD, hyperactive kid, and many times levetiracetam precipitates this behavioral worsen, rather worsens it much more. So in that case, better to avoid. Rest can be used, no issue.
I would like to ask Mohite sir, if you have, sir, any questions from out of your clinical experience, which you would like to ask or share with us, sir.
So I wanted to ask Mahesh, that case of Syncope, which was already on Livera, you got the EEG positive and you diagnosed. Did you stop levetiracetam or continue?
तुम्हाला काय वाटतं काय केलं असेल?
Just one addition. ACTH, I'm sure peripheral people may not be having an access to it or feel apprehensive about it. Alternative option is high dose prednisolone. You can use almost 4 to 8 milligram per kilogram as per the newer guidelines.
And 4 to 6 milligram. We use 4 to 6 milligram very commonly. Results are quite encouraging. Like many of them, we have resolution of hypsarrhythmia in that case.
Right. And you differentiated absence versus complex partial as aura. Which one is having aura? You said complex partial.
Complex focal. They will have aura. They would have, so basically dialectic seizure are temporal lobe seizures. Okay. They have blank, becomes blank. They may have abdominal aura. They may have other aura depending upon the site of origin.
And what is your first line of choice, drug choice in adolescent girl who is obese for first episode epilepsy?
Adolescent girl with obesity. So in that case, we use levetiracetam either, or we use lamotrigine. Lamotrigine is something which acts quite good. Problem with lamotrigine, problem with lamotrigine is like it takes like 2 to 3 months, 1.5 to 2 months to have that peak. Initially, we start with very minimal dose to avoid the risk of rash. So it takes time. We can use levetiracetam very freely with an add-on of maybe clobazam in that case. And topiramate can be, if really weight is that morbid, in that case, the other drugs like topiramate and zonisamide, these are 2 drugs which causes weight loss. So that can be a good maybe add-on for here.
The question to you. We are seeing those odd shadows with encephalopathy. How often you're using blanket steroid or IVIG for those patients? Because many times the immunological workup takes time. Many times you don't have a definitive diagnosis. like something look like possibly ADEM. Now it's many times a clinical diagnosis today. The immune workup may take, or something like autoimmune encephalitis may take 1 week, 2 weeks from the Nemans. So is blanket immunotherapy advisable? And if so, which one?
We would not really look at blanket immunotherapy for each and every child. If the setting is right, your imaging is not throwing up any clues, because that's the first thing that you would actually look for. And your CSF, as it most likely will always come up not showing any organism, neither being more for viral nor more for bacterial, which is the usual thing. Then you would probably look for additional clues, maybe an EEG, which will probably give you, so let's say there is this delta brushes, then you're probably thinking of NMDA. So that setting, probably someone who has prolonged seizures and very bad status with a normal MRI, maybe that setting, it could be fires, but then you would probably also think of autoimmune encephalitis. And in that place, probably, yes, looking at the cost, primarily we're all driven by cost, even though areas of practice may be different, but the cost is the primary thing. So we would start off with steroids and then supplement IV immunoglobulins wherever possible. And if you do prove NMDA, receptor antibody mediated condition or disease, then probably the other option is plasma exchange.
Is there any role of these newer molecular tocilizumab and all? Is there any role of the cytokine inhibitors?
During this time, many people have started using the same concept of having the IL-6 as a mechanism. So anakinra was proposed and tocilizumab has been used. So it's all anecdotal reports, not like something which is definitive that this is what probably advocating in our regular practice. So yes, you would still stick to the same line, steroids, IV immunoglobulins, vis-a-vis plasma exchange, depending on what your center is comfortable to offer. And always move ahead to rituximab and cyclophosphamide, depending on what the response is. And yes, if you have really then confirmed with the NMDA receptor antibody status.
Just yesterday's patient, sir. Mohite, sir. A&E.
Yeah. That's the reason I asked you. Actually, there is one, I was telling Mahesh also, Dr. Lokesh Lingappa from Hyderabad. They have done published a study of 37 cases of A&E, where they used tocilizumab upfront within first 24 hours. And he's concluded that it has definitely a better survival rate. But I'm sure the morbidity you cannot avoid because the damage is already done. So prognosis is bad overall. Less than 4 years, I agree. Prognosis is very bad.
Sir, actually, Shekhar sir has not spoken about CSF as means. What are the tests, battery of tests of CSF which you should do in such cases of acute febrile encephalopathy?
The routine microscopy is the
Most of
and then based on the differences, yes, low sugars, you're going more towards a bacterial thing, looking for the cellularity with normal sugars, you're probably leaning more towards a. But within by itself, just a single routine reading may not really segregate these things. So when we're talking about a first picture, which you probably are leaning towards a viral etiology, then the PCR techniques that are now available, BioFire panel or an acute encephalitis panel, this may help you to actually identify an etiology for the viruses. The other thing that you do is sometimes you may not pick it up on the CSF, but we actually send now the nasopharyngeals if you are looking for a respiratory pathology as a presenting feature for your encephalitic illness, then the nasopharyngeal secretions can be sent and you can actually pick up the virus from there as well. So you have to supplement and look at your primary presenting symptom and use that organ system to send the tissue or sample for diagnosis. But PCR-based techniques is the way forward.
Now looking at the list of medicines which we start empirically in cases of acute febrile encephalopathy, So should we consider doxy and azithro, considering the rickettsia and mycoplasma as one of the etiologies for this encephalopathy?
Yes, but it all depends on whether you are in a setting. Like, let's say you're looking at Marathwada, Solapur area, where tick-borne disease can be expected. Looking closer to Goa border, you're staying, you probably can expect tick-borne diseases. Then maybe, yes, you would add that to your panel. But world over, primarily it is the same thing. Everyone is looking at antibiotics plus antibiotic for atypical organisms plus an antiviral or without steroids. So that is the general bulk. So you will have ceftriaxone, you may or may not have vancomycin depending on how strongly you are expecting strep pneumoniae. Then the second would be either clarithromycin depending where you are. But in our setting, we probably would be looking at azithromycin or doxycycline. And we would add anti-malarials in our setup, which may not be there at other places.
Okay, sir. And what about steroids? Means should we, at what point of time should we consider steroid to be given to a patient, considering it as an immune para-infectious etiology like autoimmune encephalitis? At what point of time?
Well, if you're thinking of an autoimmune encephalitis, then probably right not at presentation. Maybe you, after a day, you might think, okay, I have had many things come back and nothing is giving me a clue. Then I would probably look at autoimmune encephalitis as a differential and then consider steroids. Even for HSV, the actual damage is primarily mediated by an immune response. So if you have added steroid to the regime as a single dose, you probably are reducing the injury. So per se, a single shot of steroids may not actually be difficult to actually justify, but continuing it for 5 days may be difficult to justify. So then you would wait for more cues from your clinical part as well as your radiological or investigation part to take you through those 5 days. First day, not a problem.
So there is a question how ACTH works in infantile spasms from Dr. Nilima Bhandar.
ACTH or steroid, basically all these in infantile spasm is basically form of epileptic encephalopathy. They overall suppresses the maybe immunity or that response of epileptiform activity by it hampers the spread of this. So all this, maybe steroid or maybe ACTH, they acts very similar where they prevent the part of encephalopathy. So localized discharges, many times they stays. So many of them, they hamper the spread of the epileptiform discharges.
And another question for you, sir, using brivaracetam instead of levetiracetam.
See, brivaracetam is much more now marketing compared to like levetiracetam. It is the maybe elder brother of this levetiracetam, younger brother, you can say. They say it's 10 times potent than levetiracetam. They have less side effect compared to levetiracetam, like behavioral issues, which is the major one. The mechanism of action same, side effect profile nearly same. Still, I have seen behavioral issues with brivaracetam also, though they mentioned regarding they don't have the major behavioral side effect. Efficacy wise also not that much difference. Shekhar, your opinion?
It will take time to match
Yeah,
levetiracetam.
it will take time. It will take time to maybe
Probably we
do
should
itself.
with levetiracetam.
But major like खूप जास्त difference I have never seen regard compared to shifting from levetiracetam to brivaracetam. No, many times they have also relapsed. Maybe
Cost wise,
nearly same, might maybe minimal difference, not
And-
that great difference.
dose,
Huh?
dose.
Dose 1 milligram, 1 to 2 milligram per kg to start with
Per day.
per day. Yes,
Single dose, divided doses.
twice a day. BD. It's 10 milligram per ml that comes.
Just one thing I wanted to mention, Sachin, you said about the azithromycin and doxycycline for
Yes, sir.
mycoplasma and this. Really, Microplasma encephalitis is a extra pulmonary immune mediated complication of mycoplasma. It's not a primary mycoplasma infection. And in that condition, azithromycin does not work, evidence-wise.
Okay, sir.
The treatment of choice for that again is doxycycline. So if you are giving doxycycline, that is taking care of your rickettsial as well as mycoplasma. You don't have to use azithromycin in that case. Alone doxycycline.
Okay, sir. Okay. Now, sir, most of the in febrile encephalopathy, what is the role of steroids? Now, one question is there. Injection dexa 1 mg till 10 milligram of maximum dose in acute encephalopathy, especially viral or autoimmune suspected. So, Shekhar sir, what is your opinion about starting steroids and duration and doses? If we are suspecting some autoimmune encephalitis, I think.
Single shot is not a problem. But if you want to continue for a prolonged period, you need to have more evidence to advocate the use of steroids. Either it is like an immune-mediated condition or an autoimmune encephalitis. But for your run-of-the-mill viral encephalitis, probably you are not going to actually do any benefit by using long-term steroids.
In acute phase, no, during maybe a day 1 or 2, what may be the evidence you will get for autoimmune or immune-mediated? Or most of time you need that much period to get the reports, and many times you get negative reports.
First dose you can justify. So I'm saying that you will have to follow that. If you can probably make up, there is nothing for or against. But what I'm saying is that as a standard practice, we should not put it on the prescription that I'm using steroids. When you are using for day 1, day 2, that is okay beyond a doubt. But by that time, you will definitely have your MRI at least. You may not have the other pictures coming through. Other centers may not have an EEG, but at least an MRI would be there, and that MRI may give you more clue as to whether you would want to continue with the steroids or no. So if you're looking at then very frequent seizures, then probably that may actually take you towards fires and other things where you are anyway going to try steroids. So your clinical presentation and how to move ahead on day 2 will determine whether you are going to use it on day 2 or day 3. So some you will have to look at these pointers to guide your treatment. Nothing definitive of continuing to use it.
The immune-mediated, many times you get a normal MRI. Rather, what you expect that edema and all this, no, what with infective cause, it's not. It's like absolutely normal MRI you get.
Normal and you have seizures, then you would open AE as a primary cause, either fires or AE. So then you would probably continue to use that. So if you have an abnormal MRI, which will take you more towards a very typical enteroviral encephalitis or a JAB encephalitis or something like that, then that itself can help you to discontinue. So maybe a normal MRI may actually want you to move ahead and use steroids for a long time.
And if you have a high proteins without cells, whether that's an indication for immune-mediated, or it may be maybe secondary to seizures and all this, that may be other causes for maybe raised proteins.
Using a single reading of proteins should not be dictating the choice of the steroids. But yes, in specific setting like this, you can think that when you have a higher proteins, it probably is higher on the list. That's it, but not
the resource restricted असेल ना, where the affordability is an issue. Protein
so but that is the reason why I would not advocate it as a regular thing. So then we actually just look at things may not necessarily be a true point.
Okay.
Are there any questions, sir, from audience? Now I would like to ask Dhananjay to continue with the proceedings. Thank you, Shekhar sir and Mahesh sir, for your talk and actually answering all the queries. Thank you, sir.
Thanks, Sachin.
Thank you, Sachin, and I request our dynamic secretary, Dhananjay, to give vote of thanks.
Thank you, sir. On behalf of IIP Raigad, I would like to thank Dr. Mahesh Sambare sir and Dr. Shekhar Patil sir for their wonderful presentation and in-depth discussion of important topics in pediatric neurology, which will be helpful for us in our day-to-day clinical practice. Thank you, both of you, sir, for your patient for patiently responding to all the queries in details. A special thanks to Dr. Mahesh Mohite sir for his valuable inputs as always. I thank Dr. Sachin Murade sir for wonderful moderation of both the sessions. Thank you to the Dr. Pramod Wankhede sir, President, Dr. Vikas More sir, and Dr. Sagar Khedu for organizing this event. Special thanks to Dr. Vishal Raut sir, the digital man behind every online activity of IIP Raigad. Special thanks to Dr. Barod sir for attending the IIP Raigad activity. And I thank finally all the delegates who have attended this session. Thank you all. Thank you.
Thank you.
Thank you.